Friends, we are doing valgus knee replacement using MAKO Robotic system. This is a gait of the patient. She is about 65 years. There is valgus deformity of grade 1 valgus, and there is lateral laxity. This knee is able to be brought to neutral, and even more when we do varus stress, it is coming to varus. That means lateral structures are not tight, it is actually lax. Both medial and lateral laxity is there. However, because of hypoplastic lateral femoral condyle, this patient walks with the valgus deformity, and the deformity is valgus. We have done registration, and now we are doing the points of the distal femur. You can see hypoplasia of the lateral femoral condyle, and then we check the native deformity, which is about 11 degrees of valgus, can be brought to the neutral. That means we don't have to do any much releases, and there is hyperextension of the knee, which we have to reduce by reducing the distal femur resection. Then now when we do the gap assessment of the native deformity, here we are able to see in extension medial gap is 4.5 mm and lateral gap is 5.5 mm, and in flexion both medial and lateral gaps are almost equal. That means to say that the lateral side structures are lax. One thing, this deformity is because of hypoplasia of lateral femoral condyle. We don't have to do any much releases, and as we know, there are two kinds of valgus. One is valgus with hyperextension, and second is valgus with fixed flexion. This is valgus with hyperextension. So this can be a pretty much straightforward if we follow the proper principles. This is the first panel, which is showing the bony resections. Here we are keeping the varus angle of 0 degree in femur, and when we check the distal femur resection, we have reduced to medial femoral condyle of 4.5 degrees of 4.5 mm of resection, and laterally it is just 0.5, that is brushing, and medially in tibia, medially about 2.5 mm and laterally 5 mm. As we know, most of the valgus deformities are CPAC type 3, apex distal, and tibial medial resection is lesser than lateral tibial plateau resection. And rotation is coming to 0 here, you can see, very important, and femoral component flexion is 1.5 degree, not 3 or 5 degree as in varus deformities. Because there will be a lesser trochlear bone in most of the valgus knees, our femoral component, we cannot give much flexion, and rotation of the femur, we are not giving more rotation in flexion, because if we give more external rotation to the femoral component, the medial side opening will be more, which is already more open. We have to understand that in conventional, we can use these similar principles of not giving external rotation to the femoral component. However, we are not even giving the internal rotation. We can keep the femoral component in neutral rotation, so that in flexion, medial structures and lateral structures are almost going to be balanced without much of the releases. Then we will go on to continue to the bony resection. You can see the trochlear side will be very narrow, very small in most of the valgus knees. That's why we are not able to give flexion angle to the femur. So we give usually 1 to 2 degrees of flexion only. However, in varus knee we give 3 or 5 degrees. And once we finish this resection, we will be surprised to see we don't have to do any much releases, no more confusions of angle keeping, and no confusions of rotations of femur. We will directly be able to completely balance it very well. Even the balancing of hyperextension, as we are resecting only 4 or 4.5 mm from medial femoral condyle distally, and 0.5 mm from the lateral femoral condyle. Then we complete the tibial resection. As we see here, Medially, we are resecting 2.5 mm, laterally 5 mm. As I was telling, this comes to CPAC type 3 valgus. Most of the valgus deformities are type C. Type 3 means we will be resecting more of lateral than medial, even though this is valgus deformity. You can see that we are now doing the trial implantation. Here we have got complete 0 degrees of axis, and medial and lateral opening in flexion and extension is coming to less than 1 mm in all throughout the medial and laterally. We have balanced this knee without any much releases and without much of the confusion. You can see a post-operative x-ray, looks very nice. And thank you for watching this video. If you liked it, please like it and share it to your family.